Good morning, everyone. I'm Dr. Nawazish Shaikh, and I'll be presenting on intraoperative OCT in retinal surgeries. So my session outline will be under the following heading. So I'm going to introduce you to it, discuss the utility, and then move on to a case-based discussion. So as we know, in our clinical practice, OCT has become quite important. It's a non-invasive, non-contact test, and it provides us with basically an optical biopsy of the retinal tissue. And the same efforts have been taken to introduce it into the operation theatre. The efforts that were taken was first an introduction of a portable handheld OCT system, then a microscope mounted system. The problem with both of these systems was that the surgery had to be halted while these OCT images were being taken, following which the introduction of a microscope integrated OCT system began. The advantage of this would be that the alignment of the axis was such that you could operate while you were seeing the OCT. The surgeon could see it, or it could be displayed on the heads-up display using the 3D system. However, the assistant could not see this OCT. So currently, I have no financial disclosures, but currently there are 3 systems available which are FDA approved: the Zeiss Rescan, the Hackstride, the Leica Bioptigen. All 3 are based on the SD-OCT or the spectral domain OCT technology. And the utility of intraop OCT was given to us by 2 landmark studies that were the Pioneer study and the Discover study. The difference in these 2 studies was that the Pioneer study used a microscope mounted OCT. As I mentioned before, that meant that there was a pause during surgery, which was roughly around 6 minutes per surgery. And because there was a pause, we could not understand the tissue and instrument interaction on OCT. Whereas the Discover study used a microscope integrated OCT, so it provided us with a tissue instrument interaction that was visible during the surgery. For the surgical utility of OCT, so basically it's providing us with an immediate feedback during our surgery, and it can also comment on the micro-architectural changes of our various heroic maneuvers that we carry out during our surgery. The indications would be in any patient where we're planning a membrane removal, so it would help us to assess those membranes in patients with epiretinal membrane, macular holes, vitreomacular tractions, and patients with PDR. Or in patients wherein we are planning ILM peeling for non-resolving diabetic macular edema. And as well as it would differentiate the level of bleed or exudation and provide us with an image-guided identification of surgical planes in patients with PDR with vitreous hemorrhage. So these patients, a pre-op OCT would not help us identify the planes, and doing it after we remove the vitreous hemorrhage would allow us to plan our surgery wherein we can incise, wherein we can make a plane, dissect the membranes. And it would help us in identification of occult breaks and occult macular holes, especially in patients with myopia. So high myopes and pathological myopes, they have a very poor contrast. At times, we are not even able to identify macular holes unless and until we do a pre-op OCT. In patients with a posterior pole retinal detachment, because of the height of the detachment, we might not be able to identify the macular hole with a pre-op OCT. But during surgery, we use PFCL, we use multiple adjuvants, which would allow us to identify these macular holes. And the last thing that is very important is in its development, gene therapy and use of retinal prosthesis. So although gene therapy has not gained traction in India, but as far as the US is concerned, use of an IOCT for gene therapy and retinal prosthesis are required in any of the research studies that they do. So in patients with macular hole peeling, as you can see in this video, it can help us identify the ILM flaps, and we can also identify whether these flaps are adequately covering the macular hole. It can help us identify the completion of membrane removal, as well as help us prognosticate following the membrane removal. Previously, we were prognosticating macular holes based on preoperative features such as the MHI, the minimum linear diameter. However, with the introduction of the IOCT, a study was done at RP Center by Dr. Vinod, which allowed us to assess the further utility of the IOCT. So basically, at the completion of ILM peeling, we could see some membranes or some tissue at the edge of the macular hole. This tissue was not ILM because we had already peeled that, but it was this tissue that led to the definition of the whole door sign. This study was done in 2015, 2016. And this was a good predictor of macular hole closure. So they saw that the group which had this hole door sign present had a higher success rate. All the macular holes included in the study had a diameter of more than 500 microns. So it was not like one of them had a small macular hole while the other had a large macular hole. All underwent same surgery, and this was retrospectively analyzed. And it was published in Retina as well. The second case would be a myopic macular hole with a posterior pole RD. So in this case, after posterior vitreous detachment, we can see the macular hole clearly on the IOCT, went ahead, stained it, put PFCL in, did a peeling. At the end of surgery, the stuffed ILM could be seen very clearly on the IOCT. In patients with ERM peeling, so conventionally in our practice, in patients with epiretinal membrane, we tend to double stain. We'll stain first, remove the epiretinal membrane. To ensure the ILM has been removed, along with that, we stain it again. So in these cases, IOCT would help us identify if there is presence of ILM or not. So we could save some time with the second step. That is an advantage of IOCT in these patients. So staining was done, epiretinal membrane peeling was done, epiretinal membrane does not take up the stain, double staining was done, and then we could see that there was some remaining tissue present, and that was removed. So we could have avoided double staining had the IOCT been used appropriately. Then in patients with optic disc pit maculopathy, we know that there can be presence of small cystic changes at the fovea besides NSD. There could be glial tissue at the optic disc head. There could be vitreous adhesion at the optic disc pit. And these need to be adequately removed for the surgery to be a success. So again, we can see cystic changes, we can see the ILM, we can identify the exact location of the optic disc pit, as well as ensure the completion of a ILM tuck. IOCT in other situations would be in vitreomacular traction syndrome. Our most horrifying complication would be if the deroofing of the cyst occurs and a macular hole forms. So in these cases, an intra-op IOCT would confirm this, if it's present or not, and further deciding the management in these cases. In submacular hemorrhage, we need to know which is the area where to inject the RTPA cocktail. We need to ensure that's away from areas of retinal atrophy, PED, and drusen. As well as when we are injecting and forming the bleb, there might be formation of a macular hole which needs to be identified appropriately. And as I mentioned, in PDR with vitreous hemorrhage, it can help us identify the separation planes. In other situations we would be talking about gene therapy and in retinal prosthesis. So we need to ensure that for gene therapy, the delivery is in the subretinal space, and for the Argus 2 implant to be epiretinal. And then moving on into uncharted territory. So this was a patient who had leukemic retinopathy. And in this patient, we could see some pigmentary changes in the periphery. Had we not done an IOCT, we would have never figured out that these were actually areas where sub-ILM hemorrhages had occurred previously under the vitreous hemorrhage. Similarly, in another patient with Terson syndrome, once the vitreous hemorrhage was cleared, we could identify the area of sub-ILM hemorrhage that had occurred previously. Similarly, for premacular hemorrhage and bleed, we can use an IOCT guide to understand the exact layers at which. But there are disadvantages to this. The cost, the extra time and personnel required, we need to refocus on an area of interest. There are no quantitative measurements to identify the amount of drug we inject for the subretinal or submacular hemorrhage, and the instruments do cause a shadow. So the take-home message from this is, although IOCT is useful, it has limited clinical utility as of now. We can understand pathophysiology of multiple diseases through this. It can help us document in our routine clinical practice, but we do require better resolution and stability. Thank you so much.